Welcome everybody. We are currently 42 people here and we will now officially start. So firstly, I am happy to welcome you on behalf of the International Gaucher Alliance, who has, together with the European Working Group on Gaucher disease, started this initiative of developing international guidelines for patients with Gaucher disease type 1. We are aware that there are big differences between different countries regarding treatment of Gaucher disease. In order to ensure standardized care and treatment, a consensus document on clinical guidelines is needed. Of course, taking into consideration the different challenges in access to tests. In today's kick-off session, we will exchange our views and opinions on this topic. Initially, this topic was planned to be discussed at a multi-stakeholder meeting in March this year, but due to coronavirus, the meeting had to be cancelled. However, a pre-meeting survey was conducted at the beginning of this year, and the answers to 2 questions related to Gaucher disease type 1 guidelines were shared with you, and I hope they will be helpful for today's and future discussions. There are 54 registered attendees for today's call. 23 of you are clinicians, 17 patients or patient representatives, and 10 pharma representatives. I would like to thank you all in advance for your participation and contribution. Now I will hand over to Professor Darrell Hughes to talk about the EWGGD working groups and kick off the session. Please, Professor Hughes.
Thanks, Serena, and welcome all of you. Thank you all for joining, and thank you for the IGA for supporting this venture with the EWGGD into clinical guidelines for Gaucher disease. So the EWGGD has set as one of our missions for this year and next year to have working groups to consider the way in which we are constructing guidelines, managing our patients, interacting with our various stakeholders, considering ethical issues, and considering research and science with respect to Gaucher disease. So we will broadly have 2 themes of working groups as we initiate this project: a clinical working group and then a scientific working group. And some of you will already be aware of the scientific working group looking at diagnostics and laboratory studies, and that work is undergoing with Professors Mark Gaucher and Hans Ertz leading that, with representation from each of the countries where we have stakeholder groups. So our other guidelines and scientific working group will be around guidelines and clinical aspects of the treatment and diagnosis management of patients with Gaucher disease. And so we're very pleased that this is a start-off meeting for that project today. The working groups will be open to anybody who has an interest in the area. So we're hoping that we'll be working with patients, and the IGA has been marvelous in facilitating that for us, with physicians, with scientists, and then where it's appropriate with our colleagues in industry. So not every project will necessarily either benefit from or merit having inclusion from all the areas, and in particular industry inclusion, but we'll discuss that on a case-to-case or a group-to-group basis. The meetings of the working group will be essentially virtual because of the current situation, but that also lets us have meetings that are potentially more inclusive. People won't necessarily have to travel. And we'll also be having a session devoted to the working groups at the virtual EWGGD meeting in October. And it is possible that we may have a face-to-face meeting if the situation changes in the next 6 to 12 months. We have terms of reference for the working groups, and those will be available on the EWGGD website. And Professor Shoshana Revel-Vick has been hugely active in putting together the material for the working groups and also the terms of reference. So if you'd like to join any of the working groups, and we'll talk a little bit more about, at the end of today, as to what we might be doing going forward. But if you'd like to join any of those working groups, then you can access the forms to do that through the EWGGD website. So just go to ewggdd.com and then you'll be able to navigate to the working group page and sign up for the working groups that might be of interest to you. So today we're thinking about clinical guidelines and scoping what the needs might be and what that might look like for our Gaucher community. So I'm going to hand over now to Professor Chris Hendriksz from University of Pretoria and FYMCA Medical. Chris, of course, is known to all of us for his very active work clinically in this field and also supporting education and compassionate access to patients. So Chris is going to set the scene for us, and I'm very pleased that he's with us here to do that today. So thank you, Chris.
Thank you, Dylan. Good afternoon, everybody. So let's get the technology working. And I will do a little bit of a delay just to make sure that everybody can see my screen. And can you all see the screen? There we go. So what I'm going to do is I'm just going to do a short introduction just to set the scene for us before we start talking more about it. And as you all know, my interest is purely around the LMICs, and I'll explain all of this to you, so don't worry. That's basically my scene setting. So as always, these are my disclosures, and I work with everybody involved in patients. But in this capacity, it's really as I'm helping the patient organization, the IGA, which I've agreed to help them in this project and share some of the information and knowledge that we've gathered. So the first thing is, I think, when we talk about what is a guideline, the WHO definition is most probably the best one to use. When you look at it, it says that guidelines are generally defined as systematically developed statements to assist practitioners and patients make decisions about appropriate healthcare for specific circumstances. Guidelines are tools to help decision makers make better decisions, and therefore it is essential that both development and implementation strategies are clearly focused on the end user, decision makers. So that's the definition of a guideline to start off with. The next thing is the term that I would want to bring in here that some people may know or may not have heard about is this term of being patient-centered versus patient-centric. And really, guidelines to have the greatest impact need to be patient-centric in my view, but we may not all agree. So just to explain, so patient-centered guidelines is that we as clinicians say we've used all the evidence and the experience we have to make your life as best as possible by using medical interventions. Getting your hemoglobin values normal, your platelet counts normal, with no pain are our goals, and we have all the tools to measure these outcome measures. If you make them patient-centric, it is actually different because it will be the patient speaking, saying, I want to be able to participate in potentially contact sport without feeling tired all the time, and I want to know how I can limit my risks. Oh, and I don't want everybody to see me full of those awful bruises. So you can help me to achieve that. So you can see how different it is in the way we ask the questions. But also patient-centered is usually guideline-driven, where actually patient-centered is patient and individual-driven. So the two are supportive of each other. So moving on to the next thing, it'll tell you that patient-centric guidelines should be able to answer the questions that patients have for their clinicians. These are real questions, and that's what we're hoping you will be helping us to develop with this project. However, for the clinicians, these guidelines, especially for our non-expert clinician, it should contain all the answers to these questions in easily understandable format. So guideline is the tool to support both the patient and the non-expert to achieve these goals. So firstly, as in all things in life, we know that everything has got pros and cons. So clinical guidelines are increasingly a familiar part of clinical practice. Clinical guidelines has been used since the late 1970s in general medicine and has started moving into rare diseases, most probably towards the late 90s. They have potential benefits, but they also have harms. So rigorously developed evidence-based guidelines actually will minimize the potential harms. And then clinical guidelines are only one option for improving the quality of care. So they are not the everything for everything. And it's really important to remember all of these. So I've already touched on that from the early 1970s, guidelines has been prominent across the world. But this is just to quickly look at some of the details from Africa and to show you that guidelines only started becoming more of an issue around 2005, and there's been a slow progression in process. In only 2015, so very recently, was there actually an agreement that actually there should be wider use of guidelines in our LMIC, which stands for low and middle income countries. So there is a big push to actually get them included. So developing guidelines only for the part of the world which is developed does not serve the patient population well. And that is the progress and the push that has happened to get that in. And that's where I'm talking about my passion. But because we can't ignore the elephant in the room, it is important to get a little bit of an understanding of what is actually an LMIC. So just to put it in perspective, when we talk about the GNI, the gross national income per capita, it is the dollar value of a country's financial income in a year, and that's divided by its population. To give you an idea, so for a low income country, that value would be $1,036. For a high income country, that would be over 12,500. But even in that variation, you can see that the GNI for the USA is $65,000 per capita, whereas the UK 42,000, but a country like Niger, where we've got clinicians looking after patients, it's only $560. Or Romania, which is the country which has just edged into the high income countries, 12,630. You can see a factor of about 5 times. And that is part of the challenge that we deal with in these countries with lower income. So that is just that you understand the terminology. So let's move on from there. So what are the issues for specifically for Gaucher, for our LMICs? Well, the first is that there's a lack of diagnostic abilities. So there are either limited or no laboratories able to do the testing. There are complex transport and logistical arrangements in place, which may compromise sample quality. So you may only be able to use a certain type of sample. Simple infrastructure like power or centrifuges are not available even in some countries. So it's not helpful to say you can just separate the sample, which will solve the issue. There is also the inability to send samples across borders. And this is something which we're trying to address at a high level at present, because many countries and LMICs are not allowed to send samples outside of their borders. So the other challenge is that it overlaps with a lot more common diseases. So big livers and spleen is incredibly common in infectious disease. There is a great lack of awareness. With a lack of diagnostics, you could see why we don't see the patient cohorts as we would want in these countries. So if I was a patient in one of these countries, when I look at diagnostic, my question would be, what is the definition of Gaucher disease? I would need a definition that works for me with a limited facilities, and we need to keep this in mind. When we move on, the difference is we can always talk about ideal treatments versus possible treatments. And we know that in the LMICs, there's a lack of infrastructure like continuous electricity supply, make it impossible to have ERT delivered at a local level. So it means people may have to travel to a major center far away. This comes with huge cost and burden to patients. Patients may have poor venous access, which is a particular issue for children, but there is not access to specialized techniques like portacats and BIC lines. And so there is limited facilities available to make patients' journey easier. There is also a lack of objective outcome measures from the affluent guidelines. There's no imaging available and biomarkers are not available. So we need to find things which are useful if we're going to be looking at how we're going to support these part of the community. And then when you start looking at the PRO tools, they are inappropriate. I had to have a little giggle today when I looked at the SF36. Now you can think it for yourself. If you have one of my doctors seeing a patient in Niger, you're asking them, can you please let me know moderate activities such as moving a table, pushing a vacuum cleaner, bowling or playing golf, how does that limit your quality of life? This doesn't even exist in these countries. So these are not what is helpful. So we need to look at what is pragmatic treatment outcomes for these patients, and we need to ask the hard questions. Do they need their own tools? But then also, we can't not talk about the elephant in the room. We know that there is economical influences. There is the unaffordability of diagnostics, monitoring, and therapies. The impact of rare diseases on families' annual income, their travel, their loss of time, the health economic impact on healthcare in general, and rare disease therapies are disproportionately expensive in LMICs. And I've just taken an example, so this is not a specific product or anything, but to show you a simple case that basically, if we say a rare disease therapy costs $200,000 per year, that represents 3 times the GNI in the USA, 4.7 times in the UK, but in Niger, 357 times the GNI, or in Romania, the country who's just become a high-income country, 15 times. You could see how then treatments are disproportionately expensive, monitoring and diagnostics, and we need to not put demands on patients and physicians, which is unrealistically. So patients may ask the hard questions, which we don't always want to answer, which is, what is the lowest and most infrequent dosage of treatment that will be of a benefit to me? And we need to be conscious of these questions. We can't just let that go. So these are the difficult and the hard questions we need to keep in mind. But also we don't need to be completely devoid of all the ethical issues. There is the whole debate between common versus rare disease. We also know comorbidities like HIV, TB, sickle cell, cancer are around certain parts of the world more than others. But actually, we need to know, where do we need to draw the line? Should we exclude all patients with these conditions from therapy? These are hard questions, but we should think about them. We need to also think about off-license dosing. Is this ethical versus unproven therapies? What do we choose? Off-license dosing, or rather therapy without a license? And we need to remember there are very different cultural values on treatments, and we need to keep them all into perspective. So some of the solutions could be, is there a place for an independent ethical and economic review accompanying a set of guidelines? That is something I've talked with other LMICs before. Maybe you have ideal guidelines, but with an ethical opinion and a health economic review from an independent organization saying, how does that stand depending on where you sit inside these scales? The other thing as well is we need to look at the potential solutions. So I don't want you to get disillusioned. I want this to be positive and say there are solutions to all of these issues. What we just need to be clear about is, do we want to have ambitious goals and put caveats in? And ultimately, the goal of that is we're going to improve the therapy across the world for everybody? Or are we going to be pragmatic and develop guidelines with greater universal use, knowing that not everybody will be able to use them, but we can potentially put in some levels of implementation? These are the ideal values, these are the practical values, and these are the if only possible values. And these are the difficult questions which we need to keep in mind when we go forward in discussing some of these questions. So that gives the introduction of which I had back, and I'm going to hand over to the rest of the program, and I think Maggie is going to take us forward with the next phase, and I'm going to go off screen and on mute to just get the next phase started. And thank you for your time and attention.
Thanks, Chris, and welcome, Maggie. And Maggie is Professor of Hematology at University of Cairo, and she's now going to take us forward. Maggie, you're on mute.
Hello, can you hear me? Okay.
Yeah.
Can you see the presentation? No, you cannot see the presentation. Okay. So share the screen. To all panelists. Okay. Can you see the screen? Okay. So, hello, everybody. I don't know what the... Sorry about that. Okay. So, hello, everybody, and thanks, Derlin, for the introduction. I would like to thank the EWGGD and the IGA for giving me the opportunity to share in this meeting. And I really consider it quite innovative because and important as well, because it's not only going to be the treating physician's perspective included in the guidelines, but the patients, because I believe that the patients and the patient's opinion and input really counts. And I thought that the more diversity of patients to include, the better. And so these are the patients' voices. Just a quick introduction about me. I'm a pediatric hematologist, and we manage in our treating center a very big cohort of 130 patients of GD, and they are mostly GD3, but we also have a very unique GD1 patients, as you're going to see now. Actually, this is one of my patients, and this is his family, and this is another one that I'm going to share her story with you. Okay, so I believe it's time for change, and to approach change differently, we need to change our approach. So the guidelines now will be the input of the patient or the individual, as I would like to refer to any Gaucher disease patient, his family, as well as the treating physicians. And what's our goal here? It's a healthy Gaucher disease individual. And here again, I would like to point to a Gaucher disease patient as an individual, because I believe that we are all individuals and we all have problems, and just Gaucher disease can be managed as one problem. And to have a healthy individual, we need to tackle all three aspects, and that would be a healthy body, soul, and mind. Now, what did I do here to get the input of my patients? Actually, I made telephone calls to our patients because of the COVID-19 issue now. So I started by asking them 3 of the questions that we are going to ask all the attendees and the audience. And that is, what is it that you need from the guidelines? What questions would you like the guidelines to answer? How would they be used? What would you like to achieve with them? And actually, Chris's presentation was very important, and especially highlighting the definition of guidelines, because no matter how much I explained to the patients, they simply did not really got the grasp of what I mean by guidelines. So I thought I put myself in their shoes, because I usually do that, and thought like to ask them more simpler questions, questions that really can help them. So I thought maybe I would ask them these 4 questions. What do you need us to focus on or add to what we are doing? What are the current problems that we can help you with? When would you feel that the treatment has accomplished its goal for you? What can we do that would make you happy or happier? And really that rang a bell. So this is a very successful story. And actually I'm going to go through 3 stories of 6 patients. The first story is of 3 siblings with the common N300 homozygous N370S mutation. And people would think that this is not a mutation that is around in Egypt, but actually it's quite rare, but it's there. So as you see here, this is how our patients started up, and this is how they become. So at 20, so our 3 sibs are 23-year-old identical female twin and their younger 19-year-old brother who have been on ERT for 17 years. The twins have graduated from university and have been doing voluntary work in a school, but because of the COVID-19 issue, they are currently making artwork, and they have their Facebook page, and they're getting and selling it online. And their brother will join the university this year, and he wants to become a professional athlete. So that's a really successful story. But a very important issue here is that they have always been, since they've been children, because I have I would like to think that I have a close patient-doctor relationship. They have always been self-confident. They have had a mind of their own, very intelligent and bright, as you can see here, and they feel they are no different than any other individual. Now, this is the message I really want to deliver. Now, after asking them the 4 questions, this is the feedback I got. They were very pleased with the idea of us involving patients in the guidelines and thought it can do a lot of good to all patients and help many of patients who have more severe issues than themselves. And also it can clarify a lot of the misunderstandings and misconceptions, especially for patients and their families. They did not think that they had any worrisome current issue, which is very positive feedback. But they had few suggestions and some queries that I would like to share with you. So, what were their queries? Very intelligent and very bright. What is the difference between me and any other individual regarding efficiency, abilities, body function? A very important question that is not so easy to answer. And I think that we should include in the guidelines. And I think with the patients that are doing, or rather the individuals that are doing well, that's a thing that usually comes to their mind. And then the other query which was that sometimes I can do activities and the big effort that other individuals can do, whereas other times I can't. How can I judge or assess my competence as an individual? What about having children? She didn't mean that regarding having children affected with GD or the mode of inheritance, but she was asking about any obstacles because she is a GD individual. Any problems as I get older? Am I prone to other comorbidities, of course, other than malignancies? Is there any cure in the near future? What about gene therapy? We even had a discussion on genetic modifiers. Actually, our talk was around an hour, but that it was very fruitful. Now, she would only, or actually they would only consider just dietary advice, an issue that they want to learn more about regarding their condition, as well as this unsolved issue with their intermittent fatigue. And one of their suggestions was to involve a sociologist or a psychologist in the guidelines. Our next story is a GD1 individual with the rare but quite severe genotype homozygous R359Q. This is how our GD individual started and how he has become after receiving ERT for 18 years. He is currently in the third year of university and he's studying sociology. He is actually accepting his illness and coping with his life in spite of his current problems. And it took him quite a while to open up and speak his mind to me, though I consider myself a bit close to him. His current problems are severe bone disease, severe eye disease with infiltrations of the eye, affecting his vision, but he's doing okay with his glasses, lymph node infiltration with Gaucher cells, and dental bulb infiltration of his teeth with Gaucher cells. I'm listing his current problems to see that he has quite significant problems in spite of being a GD1 patient. So regarding the feedback or the reply to my queries, he's told me that fatigue and severe bone involvement are what is really bothering him, though he learned to deal with it. And I would say he's dealing with it quite well, in spite of being quite frequent. He's wondering about work and traveling and asking for advice in these issues. And it would be great if it would be included in the guidelines. It's one of his unmet needs. Now, this is really important, and I want to highlight this. Now, home therapy for this patient and for the rest of our patients, thanks to COVID-19, because I believe everything has a positive side to it, has really been an important factor that many of our patients now are receiving home therapy. And home therapy has done him really wonders, especially because of his education and especially that he is really clever young man. One of his suggestions that is really important and I think we can implement is telemedicine. That I think together with the home therapy can really make a lot of difference to the quality of life of patients. So thanks for the IGA for having homes, not hospitals, improving patients' quality of life for the Gaucher Disease Day as a slogan. Now, this is another different story. This is two GD1 siblings with intrafamilial heterogeneity and a relatively severe disease. They are 9 and 11 years old, and they've been on ERT since 5 and 6 years respectively, but they're not doing well. But that can be partially actually attributed to interrupted dosing. I think this is one of the things that we also need to include in the guidelines. So this is how they started off and how they are now. As you see, I mean, I believe that pictures can speak louder than words. So they're not really that happy. The girl is having severe bony issues and bony aches and recurrent fractures, and the younger boy he's having growth issues, and actually he's being bullied at school because of that, as well as because of his not responding organomegaly to the therapy. So I really want to thank my patients because I believe that I owe them so much. And I think this is an opportunity now of them sharing in the guidelines to help make their lives much better. As well, of course, I would like to thank the whole project because they have, this is how we started off giving our patients through the HEAL Project Sanofi Enzyme Humanitarian Program, their enzyme therapy. And special thanks to our GD nurse, who was very good, very active, serving this program for quite some time, but unfortunately, he passed away recently. And this is actually the Rare Disease Day, and this is the mom of the young man with the GD1 homozygous R359Q, and we were giving her a certificate of appreciation. Thank you so much.
Hi, everybody. I shared my screen just preparing during this, I think, great opportunity meeting, a brief summary of what we heard and some thoughts how we can continue from there. Basically, as I see it, we talked about 5 topics that probably can go into separate working groups in this guideline or guidance initiative. So the first one will be more on diagnosis, and I just put a points here. I'm not sure it's conclusive, and I'm sure many might be other things that I missed, but talking about the phenotype spectrum and differential diagnosis, genetic counseling, criteria for diagnosis, in different places in the world, disease awareness. So that will be the first working group. A second working group can write guidelines on treatment and monitoring, and really taking the points that were heard during the talks, and also from the points that were I took from the survey of the IGA that was sent earlier. I think a very important working group will be on that outcomes that are important for the patients. And here again, I put in very important things that were raised during this meeting. And I totally agree with the idea that we should add to the different working group maybe some experts from other fields, or at least having them as a consultants, especially for the sociological aspects or other aspects that are important for the patients. And then a working group on the management of comorbidities, disease-related complications, life events, as I highlighted here, like Parkinson, malignancies, all the points of osteoporosis. And also I agree with the point that we probably don't have to invent the wheel in every aspect. We can probably take from other guidelines that are already agreed. And then the last working group, which I thought would be interesting, is really to do the talking about the universal approach. And we heard ideas of doing extended supports or satellites or telemedicines, and I think there is a lot to talk about it, about how to do it, and ethical issues about it. And I think it will be an interesting working group. So this is how we thought we can proceed with this. This is an email of the EWGGD that I urge you to use, and if you are willing or wanting to be in one of the working group, then we will have a list of people in the different working group, and then we can put you together in a mailing list, and we will take the advantage of the coming EWGGD in October to have the working group meeting. Hopefully we'll be able to go into different rooms and really start going deeply into the different topics of the guidelines. So that's my thoughts of how we can proceed from here. And I will let Darlene conclude this meeting.
That's wonderful. Thank you so much. And thanks for actually compiling that during the meeting. So the next steps from here are, if you're interested in joining, then get back in touch with us on that email address. We're also going to contact all of you and explain how you can join a working group. So if you've missed the email address or the website, don't worry, you'll get an email from the organisers of this meeting explaining the next steps. Once you've decided which working group to join, then we'll come back with some practical steps around meetings and how that is going to work out over the next few months. Please do have a look at the EWGGD website, because that does give details, and also details of how to register for the virtual symposium in October. And that's going to run over 2 days, over the Monday and Tuesday, but the Monday morning will be devoted to discussions around working groups and hopefully some practical working group meetings, started to thinking about what the guidelines might look like. So you're all incredibly welcome to join those. There's just a question on the chat about will the presentations be available? I believe that the PowerPoints and the presentations will be made available, subject to the speakers being happy to share. Sometimes it's a bit more tricky with clinical data, so we'll come back to you about that. But the meeting has been recorded so that we can give you some of the information back. So thank you all again. Thank you for all of the speakers, to the IGA for arranging and hosting this, and to working through all of the pre-meeting material. And I just hand over to Irena now for the final closing. Thank you.
Thank you very much, everybody. I'm so happy that most of you stayed until the end. So still we have 40 people on the call, and I'm so happy for many of you who shared your opinion and thoughts. So please keep thinking about this topic, and I hope we will manage to create good outcomes and good guidelines for type 1 Gaucher disease. So thank you, everybody, and have a nice day and have a nice time. Bye-bye.